Hello, my name's Alison. I'm a clinical psychologist presenting for myself and my colleague Nechama, who can't be with us, on the recognition of autism spectrum condition amongst women and girls. Okay, so I'm an Irish white woman with light brown hair, a white shirt in a white office, and a green plant in the background. Okay, so yeah, the numbers definitely capture what most people know from experience, which is that men and boys are diagnosed with autism spectrum condition much more frequently than women and girls. And the gap is biggest amongst adult women, and the girls and adolescents who are getting diagnosed, they tend to be identified because they're the girls who are in the most distress or they're struggling with other difficulties. So they might have mental health problems or be diagnosed with a learning disability identified through education. There's other reasons often calling clinicians' attention to them, and they're coming through for referral that way. So all of the information we know about autistic women, what I would say possibly autism in general, it does tend to be framed through this lens of the people coming for diagnosis are often coming at the maximum point of distress. The team that we work in, like all mental health or diagnostic teams, has to use a standardized checklist to make the diagnosis of autism spectrum condition. We use something called the Diagnostic and Statistical Manual 5, the DSM-5. And all of these checklists, they're based on observable behaviors. And I would say they're based on observable behaviors defined as problems by neurotypical people. And the problems identified are around social communication and interaction, restrictive and repetitive behavior, interests and activities. And what Nechama and I and the team at large try to do is, yes, adhere to these checklists, but through including additional interviews with the young person, the family, observations at college, we're trying to do something that's also much broader, trying to think about what have we learned about autistic experience, through the self-reports of autistic people, what does autistic well-being look like, so that when we come to the end of the assessment, we're not simply framing a whole list of problems, but that we can begin to think with people about what's their unique individual way of processing sensory information relating to others, thinking about the world. So there's a couple of different ideas about what could account for this difference in the rates of males and females being diagnosed with autism. Some of them put forward an idea that either biologically or cognitively in our thinking style, there might be a different female to male brain. The females might be more empathizing, males might be more systematizing. Some other ideas say, no, it's not that there's an underlying difference, but it's also about the way in which girls are socialized differently in society, that the women and girls are subject to more pressure to comply, to be socially engaged or caregiving, and that leads to the women and girls unconsciously taking on some kind of masking or suppression of their true human experience. And then there's also ideas around the standardized tests, that often these observable checklists that are being used have been developed in studies with largely boys and men, so they're more likely to pick out more boys and men in the future. The DSM-5, even before it came out, actually, the working group were identifying what the new list of observable behaviours were going to be. And at that point in the academic literature, people were already looking at this new list of observable behaviours and saying it's not going to quite pick up on what we're observing with women and girls. So, for example, traditionally, some of the things you might look out for are, difficulties sustaining relationships, but often clinicians were pointing out that autistic women and girls may well, especially in primary school, have groups of friends. They might be quite mothered or taken under the wing of other young people. It might be that they feel pressure to interact socially, so we're not noticing them in the same way. some people have also said that whereas there's sort of some of these classic stereotypes around autism, that someone might have a special interest in some obscure piece of mechanical equipment, doesn't apply to girls. They might well have special interests or collections, but they might be quite similar to those of other young people. But I think what you see through all of this is that it kind of retains this focus on there being a problem, and some of the ideas are very gendered, that there are these innate differences. More recent thinking from Tony Atwood and Michelle Garnett, two psychologists who did a presentation last year, was inviting healthcare clinicians to think about, is there a difference in terms of the cognitive profile, that autistic young women, for example, might be better at remembering facts, or they might be quite accurate in terms of pointing out differences or correcting errors. But for us, yes, we're kind of trying to think about, are there marked differences in the observable, outward looking in traits for autistic experience and autistic women? But also what we're really interested in is listening more to the autistic community to hear what it's like from the inside out. So for example, this young person, Kay, received a diagnosis, and she said that it gave a lot of validity to her rituals and routines, which might have been framed as an observable problem around being restrictive with food, but actually being able to have a space to think about what this was from the inside out. She was able to talk about a very rich sensory life. But a byproduct of this was a sensitivity to particular textures that she wasn't going to eat. And she also had taken in a lot of narratives around getting it wrong socially, and the observable checklist of behaviors did mark her as scoring in the difficulty range for social and emotional reciprocity. She didn't necessarily feel a natural curiosity about the interests of others. But thinking from the inside out with her, we were able to tell a story and capture into her report what were the ways that she does connect with others, what were the ways that she does feel that she has social and emotional reciprocity. And for her, that was about noticing how close she feels with people when she's able to do a sort of information dumping, of being in the presence of another person who's listening and engaged while she's in the state of flow, talking about one of her passions. And again, I think that links with the importance of things like sensory experience or people's interests, not just being framed in terms of an observable problem, but making sure that the assessments we're doing are capturing the creativity and the richness that they can bring to other people's lives. And very importantly, hopefully out of the assessment process, people are getting to a place where they can advocate for themselves, that whilst these checklists list observable from the outside difficulties with an individual, being sure that we are thinking about things and making recommendations for the outside world to adjust, and empowering people to know about things like the Equality Act. So what kind of things go on around diagnosis? Well, certainly Nechama and I would talk about this idea that the girls might go undiagnosed, they might fly under the radar. Definitely what our experience of talking to women and girls who've come through the clinic, both therapeutically or for diagnosis, are very strong stories about being a woman and the pressure to be socially engaged or caregiving in some way. I think for us as healthcare professionals, there's a lot to think about in terms of misdiagnosis. So I haven't gone into detail on it here, but the autistic community have many brilliant resources on the idea of autistic shutdown and meltdown, which in a way are two extremes of the stress response. Either we slow down, we dissociate, pull back, go into a state of shutdown and collapse under real pressure, or we might upregulate and become very overwhelmed or anxious. But perhaps in either of these two states, perhaps autistic women, especially with discourses in society about women being emotional, maybe they're more likely to be seen as anxious or depressed. Where learning difficulties are diagnosed, perhaps all of the professionals and the systems around the person become focused on that, and they might miss the autism and the autistic experience. But for me, I think what, has resonated with me in a very deep way, especially when offering therapy to autistic people, is how often our failure as neurotypical people to understand the autistic experience can in and of itself create mental health problems. So there's an idea around mentalizing in society that, to know my own mind and to have a feeling of being understood comes in part from another person being able to be attuned to that and to reflect it back to me. So it's a relational process. And if we have mismatches for a whole range of reasons, be it life experiences, other traumas, but it could in some cases also be a mismatch between neurotypical society, family, school, healthcare system, and the autistic individual, that can create a kind of relational trauma or relational harm. And I think sometimes what I've seen then is in the consulting room, when people are trying to think about what's autism spectrum condition or what's not, there can be an idea that, well, perhaps this person is presenting with what's sometimes called a personality disorder or complex trauma rather than autism. And sometimes I think it's about, well, it's both and perhaps if an autistic person has had multiple experiences of being very misunderstood in their life, they may well present with complex trauma. And this is kind of recognised and thought about in the autistic literature too. Damien Milton, sorry, just going back there, has talked about the double empathy problem. And I think that's something that we've tried to bear in mind very strongly in the autism assessments. One of the things we noticed at a Team Away day was that there was some evidence coming through about the experiences of late diagnosed women, talking about how difficulties understanding certain social situations made them more vulnerable to abuse. This is an area I'm interested in learning more about. I'm working in forensic cams at the moment, and looking on a case-by-case basis, I do wonder if there is a group of young autistic women who are out there and more likely to be exploited in different ways. And the links with that, perhaps with the pressure to be normal or to mask, that can cut a person off from their innate gut reactions and their own threat detection systems. So these are just some of the things that I'm thinking about and trying to learn about at the moment. The idea of masking, I think, can be very psychologically harmful. This communication that you have to, in some way, deny your own experience. It's been linked with suicidality. Certainly it's spoken about a lot in the autistic community as something that's quite harmful. Another area that I'm learning more about is the importance of the whole sensory experience, about interoception and your ability to interpret signals from the body and how that links with emotional experience, but also your capacity to know your own needs, which is really important for autistic people when they're going to be setting boundaries. And there's some wonderful work on this by Rachel Thompson, who's an autistic woman, who does a regular free presentation on her sensory worlds. The slides are freely available, and often she does a workshop as well. If you go back to kind of the moving away from the autistic experience and trying to understand and include as part of our diagnosis what it might be like from the inside out, in terms of the standardized tools, Tony Atwood and Michelle Garnett and some other colleagues are developing a new questionnaire at the moment that tries to pick up what are the areas of greater reported difficulty for females, how were autistic girls differentiated from non-autistic girls. These are some of the things they're picking up on. And these standardized tests and checklists are always going to be part of the diagnostic process for the foreseeable future. But alongside that, what we're trying to do as much as possible is to go back from this inside out perspective, to try and hear from autistic women. This is a great video by Sarah Hendrickx on the National Autistic Society, to factor that into our thinking, and to really try and promote post-diagnostic work around helping people to be in touch with their own unique well-being, to reclaim joy, not only to portray things like stimming as a restrictive, repetitive behavior, but something that can be purposeful, but life-affirming in a way, and giving people a space to think about autistic culture. In what way are they a partner or a parent? Space sometimes to work through the shame-based stories, the loss, the sense of ableism that people have taken in, and hopefully setting people up with empowerment to be able to set boundaries, do some energy accounting, and ask for reasonable adjustments if they need it. And finally, I suppose, always just keeping an idea on what's happening in the moment, that the NHS practice and the academic literature, it's slow to catch up. But my experience in the last 10 years is I've learned more probably about the autistic experience and things that I should be trying to think about as someone who takes part in making the diagnosis of autism from autistic people themselves. And the Academy, I know, I saw that Chloe Farhar is on the lineup earlier this morning. So, I just wanted to acknowledge her work and also the work of autistic people in general. That's definitely shaping the way that we think about diagnosis. So I've gone over slightly, so I will thank you for your time, and look forward to meeting some of you in the Q&A after the session.